Hello, and welcome to this afternoon's presentations of Preparing for the Future. My name is Janell Reichuber, and I'm a nurse at the University of Kansas Health System. Today, I have the honor of introducing our next two speakers. Our first presenter is Heather Bachert. Heather is a board-certified nurse practitioner who works in collaboration with the ILD pulmonologists at Henry Ford Hospital in Detroit, Michigan. Heather specializes in patient education and improving the well-being of patients with ILD. She works with her team to help diagnose, treat, and manage a large population of patients in Michigan. Heather will start us off with her presentation on palliative care, which will include managing your symptoms to improve your quality of life, how to access palliative care, and the maintenance and insurance requirements that go into it. She will also present on the differences between hospice and palliative care. Our second presenter for this session is Lanier O'Hare. Lanier is a CRNP at the University of Alabama at Birmingham. She works in the sarcoidosis and ILD clinic at UAB and is passionate about educating her patients. Lanier is currently working on her PhD with a focus on quality of life and pulmonary fibrosis. Her presentation is on how to talk with family and friends about pulmonary fibrosis. So please, sit back, enjoy these talks, and get ready to type out those questions for our Q&A session after the presentations. Thank you.
Hi, my name is Heather Bachert, and I'm a nurse practitioner at Henry Ford Hospital in Detroit, Michigan. I work there with the Interstitial Lung Clinic, and I'd like to talk to you today about palliative care and interstitial lung disease. Some of the topics we're going to discuss today are what is palliative care? How can it be helpful to you? Managing our symptoms and improving quality of life, some insurance requirements, and we will end with some case studies. So what is palliative care? Palliative care is a specialized medical care for people living with a very serious illness, such as lung disease. It also can be other diseases as well, like heart disease, end-stage cancer, AIDS, Alzheimer's, kidney failure, among many others. It's focused on providing relief from the symptoms and stress that an illness can cause. The goal is to improve quality of life for both patients and families. Both palliative care and hospice care can provide comfort, but people can move in and out of palliative care as their needs may change. It's based on the needs of the patient, but not necessarily the prognosis, and it is appropriate at any age and any stage. It's important to note that palliative care can begin at diagnosis and at the same time as other treatments, and even while pursuing a cure. Palliative care is a supportive care, and it's an adjunct to existing treatments in hopes to keep patients as comfortable and active for as long as possible. A little bit of history about palliative medicine. It was founded by a British doctor and started in the form of hospice around 1948 for patients with terminal illnesses. It was often delivered by members of churches and religious organizations. And then palliative care was developed sometime thereafter. There's been more education and focus on palliative care recently. There are now 1,400 palliative programs across the United States, and approximately 80% of large hospitals have a palliative program. Lately, we have found that studies show palliative care in patients with lung diseases is not always consistent, and the majority of pulmonary fibrosis patients do not receive a formal consult. As more and more patients and providers and families become aware of the benefits of palliative care, we are optimistic that this will change in the near future. Palliative care uses a team approach and consists of doctors, nurses, and social workers. It also can include chaplains, psychologists, dietitians, and physical and occupational therapists. Palliative care, everyone works together in palliative care with the patient's existing team for additional assistance for the patient. So you may ask, why do I need palliative care? Every patient with an active, progressive, and advanced illness has a right to palliative care. It can help relieve symptoms and suffering and provide the best quality of life for patients and families. It also can help families function better on a day-to-day basis. Some of the benefits of palliative care. So early in disease, palliative care can help with future care planning. It can give peace of mind to patients and caregivers when facing the advancement of the disease. And then later in disease, it can help decrease the feeling of breathlessness, cough, pain, anxiety, and more. And it can assist the patient's ability to die in the comfort of their own home if they want to, and improve the caregiver burden at the end of life. So where is it provided? It can be given in many settings, including in the hospital, in the clinic, and in the patient's own home. Some studies have shown patients who receive palliative care have actually lived a few months longer than expected, which may be due to the effectiveness of treatments for depression, improved management of symptoms, and even less need for hospitalization. You may ask what techniques can be used to help with symptoms other than medications. Of course, we do use medications with palliative care, but currently being studied are fans, pacing techniques, individual exercises, breathing techniques, anxiety reducing techniques, pulmonary rehab, and some nutritional changes as well. And traditional methods may include relaxation techniques, emotional and spiritual support, and of course, support for children and family members. Caregiver needs. We mentioned caregiver needs a minute ago, so I'll expand on that briefly. The palliative care team attends to physical, emotional, social, and spiritual quality of life of the patient, but also can affect many aspects of the caregiver. Since palliative care tends to be a holistic approach, support services can also help educate family members about illness, treatment, and provide respite as needed, and even provide resources for transport and meals. This can overlap with the care that hospice provides as well. So keeping families informed, knowing what to expect, and preparing for the ups and downs. Some practical tools that it helps family with is tips for bathing, dressing, meals, things like that can make things easier. And as far as stress, palliative care takes time to listen and focus on things that can be controlled, such as small daily goals or returning to things that can cause joy. So who pays for this service? So I would say check with your carrier or healthcare plan to find out what's covered and whether or not you're responsible for any copays or out-of-pocket costs. Medicare, Part B, and Medicaid do cover some types of palliative care, but there might be copays involved for treatments and medications. This would be true as well for private plans, which usually do cover palliative care, but there might be some additional costs. Everybody is unique, so everybody is different. Everybody has their own story, and palliative care respects the individuals and everybody that's different. For example, some patients may have a goal to live as long as possible, no matter what the quality of life, but others may want to focus on shorter time with a better quality, while yet others might need more emotional support and spiritual support. I first encountered palliative care over 20 years ago as a nursing student. I helped care for a 16-year-old patient in the hospital in an inpatient setting, but as a palliative care unit. She continued to have treatment for her illness, but it was for palliative needs at that time. She had her own room, she had her own space, but she still received a lot of assistance and care from the team. They helped coordinate services and of course helped a lot with her pain and shortness of breath. I remember being very sad about her diagnosis and her prognosis, but I was also very impressed by the care that she received and the fact that she had control in the treatment that she received. I want to talk to you now about a few case studies that I have seen of patients I have seen more recently. The first case is a 70-year-old female with interstitial lung disease, pulmonary hypertension, and connective tissue disease with significant shortness of breath and hypoxia or low oxygen levels. Her goal was to work right up to the very end of her life, as well as attend her grandson's sports events as much as she possibly could. Even though she could not walk far, she kept going and going. We treated her with whatever treatment we had to make this possible for her. We introduced the option of palliative care early, but she did not feel like she needed the help. Eventually, she did sign on to the palliative care for further assistance. In her case, I believe it was mostly that her family could have the help, but she did end up working right until a few months before she passed away. Another case is a 50-year-old male with interstitial lung disease, pulmonary hypertension, and connective tissue disease as well, on high flow nasal cannula for over a year at rest. Was not a transplant candidate at that time. Our team had been encouraging palliative care for quite some time, but he wasn't ready. He wanted things to be on his own terms. Due to his age, he was young and being hopeful for a change in his health. Was not receptive to hospice at all, but may have benefited from palliative care, but did not want it. So we respected his wishes. A team social worker also assisted with this case and helped counsel him. And eventually the patient finally did request palliative care and was very thankful for it, and is still able to help him in the home and check on him very frequently there. The third case is a 75-year-old female with interstitial lung disease, which was IPF, or idiopathic pulmonary fibrosis, and pulmonary hypertension. Was on antifibrotic medication. Again, not a transplant candidate, but this time due to age, even though she pursued many sites across the country. Eventually, on the last admission, she finally became open to palliative care, and she was receptive to it. And we did start that as inpatient. The medication that she was given significantly helped her shortness of breath while in the hospital. And after leaving the hospital, she signed on to palliative care at home and enjoyed the comfort of her own home in her last several months. And the fourth case is a 79-year-old male with interstitial lung disease, again, IPF with emphysema, had a decline in lung function and increasing oxygen requirements over the last year, as well as an increased cough. The team felt it was appropriate for hospice, but the patient said no. The lung function and increasing need for more and more oxygen did predict the poor prognosis, but he, for his own reasons, was hesitant to involve any other help, but eventually finally asked for help because he wanted his wife to be able to have a little bit of rest. Eventually, he enrolled in home palliative medicine, which significantly helped his symptoms and comfort. And the last case for today's session was an 88-year-old who lived on a farm, took care of all the land, took care of his wife as well, who had many medical issues. The patient took part in clinical trials that we had going on, but the cough and shortness of breath continued to be a burden for him. After many conversations, palliative care was offered, which was home care. And actually, he did accept that, and that was very helpful to him and his wife and his family, with monitoring and assisting in the home. These are just a few of the cases that of some of the most wonderful patients I've had the privilege of meeting over the past several years. I hope hearing their stories was helpful to you, and I hope learning a little bit more about palliative care may benefit you, a friend, or a family in the near future. I just wanted to also thank the team at Henry Ford Hospital for working, and the working group at the Pulmonary Fibrosis Foundation, who is writing a palliative care statement. And then most of all, my wonderful patients and families who have taught me so much and continue to teach me so much every week. A few resources are available. If you have further questions and concerns, you can certainly look those up at your convenience. Thank you so much. I want to talk a little bit more about the differences between palliative care and hospice care today. Again, my name is Heather Bachert. I'm a nurse practitioner at Henry Ford Hospital in Detroit, and I work in the interstitial lung disease clinic there. It's nice to be with you today. So what is hospice care? It's a very special kind of care that focuses on the quality of life for people and their caregivers. It's also a compassionate care for people in the last phases of incurable diseases so that they may live fully and comfortably at home as long as possible. Hospice care begins after the treatment of the disease has stopped and when it's known that the patient will no longer survive the illness. It's patient and family focused. It recognizes dying as the normal process of living, and it uses a team approach. The majority of people want to die at home. So when and why choose hospice? More and more people are choosing hospice at the end of life. It's like palliative care. Hospice provides comprehensive comfort care as well as support for the family. But in hospice, attempts to find a cure has been stopped. It's offered when medical teams believe there are less than 6 months to live if the illness continues to run its natural course. Eligibility. So who is eligible for hospice? Hospice eligibility requires a patient's doctor or provider and a hospice provider to determine if the life expectancy is around 6 months or less. Since interstitial lung disease or pulmonary fibrosis is often unpredictable, doctors use their clinical judgment and experience to determine what the prognosis is. There's not a 6-month cutoff, but a doctor needs to reassess every 6 months to see if hospice is still appropriate. Patients or family decision makers may decide to end hospice care at any time if they do not feel that they're comfortable with it anymore, if they do not feel it's needed for themselves anymore, and they want to try different therapies. So where is hospice provided? Hospice is an approach to care, so it's not really tied to a specific location. It can be offered in the home, and it can be offered in a facility such as a nursing home, hospital, and there's also specific hospice care centers that only deal with hospice patients. Like palliative, hospice uses a team approach. Some team members include doctors, nurses, social workers, spiritual advisors, and volunteers. Everyone works together with the individual and the family and friends who are surrounding them. Volunteers are often available to do things like running errands and can give short respite care and short-term care relief for caregivers. If the patient is at home, a member of the team visits on a regular basis, maybe 2 to 3 times a week is what I've seen in my experience. But there's also somebody available, often a nurse, via phone 24 hours a day and 7 days a week. Palliative care and hospice. So I'm talking a little bit more here about the similarities and differences between palliative and hospice care because they do overlap a little bit. Both treat people with very serious illnesses, but with hospice, the medical team feels like the time is short. Both aim to treat the symptoms. In palliative care, treatments are often continued, as we said before, but hospice focuses mostly just on symptom relief. Palliative care is an added layer of medical, emotional, and spiritual support, and it can begin at any time after the diagnosis. Some benefits about hospice. Families of individuals who receive care through a hospice program are more likely to be satisfied with the end-of-life care than those who do not. Hospice patients are more likely to put pain and symptoms such as shortness of breath is controlled. Hospice patients undergo less tests and take less medications that may not be necessary compared to those who did not undergo hospice. I wanted to talk a little bit more about shortness of breath and how these teams can help with that. Both hospice and palliative care use therapies to help manage shortness of breath. Shortness of breath is also called dyspnea. You may have heard it being called that before, and it's associated with many chronic diseases such as interstitial lung disease and idiopathic pulmonary fibrosis. Shortness of breath can trigger panic, when in turn makes it even more difficult to breathe, often leading to trips to the emergency room. Some medical methods. So research shows that morphine given in very small doses in the hospice setting can reduce air hunger. Low doses can help patients relax and then catch their breath, and then they just feel more comfortable and less short of breath. It does not make the patient really sleepy or confused. Non-medical methods can be very helpful, such as, we talked about this before, but fans, breathing techniques, relaxation techniques, correcting posture, temperature and humidity control, and reducing air irritants are both used in palliative and hospice care. Now a little bit about advance directives, which you may have heard about already. Advance directives are legal documents that describes the healthcare wishes a patient would want to receive if they cannot speak for themselves. A living will and a healthcare proxy or spokesperson are the main focus of advanced care planning. Advanced directives gives direction to the healthcare workers and the family. It can be done at any age, helps plan for the future, and can be adjusted as a situation changes. I would ask your doctor for the paperwork. You do not necessarily need a lawyer for this. Some states require the paperwork to have a witness signature, so it does vary state by state as to what they require. And after they're filled out, I would say give a copy to your doctor that they could put in your chart, and also have your family or decision maker have a copy of this as well. I wanted to talk about one case study that I had seen recently. It was a 78-year-old female with IPF and COPD, was on antifibrotic medication for a few years, had stable oxygen levels for several years, and was only on 2 to 3 liters of oxygen. She enjoyed traveling and camping. She had worsening fatigue and low energy levels, as well as increased shortness of breath over the past year with low exercise tolerance. We had ongoing goals of care conversations with her and her family, and she decided on hospice on her own terms. When we last seen her, she could only walk about 30 meters, but she wanted to continue on the medication, the antifibrotic medication, as long as possible. But she also wanted to continue to camp and go up north and see different areas of the state for as long as she possibly could. She had many connections and many friends in that area, and she wanted to be with them as long as possible. Due to her increasing symptoms, and then her family was unable to assist as much anymore, she signed on to hospice and enjoyed her last few months up north in the area that she had been camping for most of her life. I have some additional resources and references that are listed here. If you need any more information about hospice care, you can look up a couple of these sites as well. And I want to thank you again for listening today, and thanks to all my patients and families who I continue to learn so much from. Thank you.
Hi, I'm Lanier O'Hare, nurse practitioner with the Interstitial Lung Disease Program at the University of Alabama at Birmingham. We've heard some amazing talks so far about some important topics to prepare for the future, such as palliative care, hospice versus palliative care, both of which can have a profound impact on quality of life. And so now I'd like to turn your attention to another important aspect of your journey with pulmonary fibrosis that can have a large impact on your life as well. And that's talking with your family and friends about pulmonary fibrosis. You know, how you might consider inviting them into a discussion about this diagnosis that you're living with. There are several important considerations to take into account as you navigate this path of information, from being informed of your diagnosis to informing your friends and family of your diagnosis. So as we talk about how to discuss your diagnosis of pulmonary fibrosis with friends and family, we're going to break it up into several sections. First of all, why bother having the talk at all? Next, we'll talk about how to prepare for the talk, and then what to do when you're actually having this discussion, and then some considerations to have after this discussion is held with friends and family. So why is it necessary to have this talk? Before we start with the rationale for having the discussion, let's first address some of the barriers you may have or have had. The first is protection. You know, this is a social dynamic where protecting those closest to us has been around for many, many years. We do this to maintain a family unit, to maintain a friendship circle. It simply helps perpetuate our being, and it's a huge part of why we are here today. But what about when we protect people by withholding the truth? You know, we think we are doing good by withholding the truth at times, and it may even be conceivable to do when withholding the truth from someone lacking the maturity to handle it, maybe like a child, it would be appropriate in this setting. But it has been said that if you respect someone, then honor them with the truth. You may also feel as though your diagnosis and its implications will be a burden for those around you, and therefore choose not to share it with other people. You may also feel like this is a private matter or none of your business. But remember, you don't have to open up to everyone. Now let's look now at some of the benefits of talking with others about your diagnosis. By letting others in, you're going to invite support. And this may be emotional support or logistical support. Emotional support can come in several different ways. Being honest about your emotions, especially with close friends and family, can be very helpful. Acting cheerful or resilient when you're not feeling that way can be absolutely draining. So simply sharing that you have some fears, anxiety, and stress, maybe even some anger, can help ease those emotions. Support can also take the form of logistical help with matters such as transportation, maybe childcare, household chores, medical equipment, or even helping you to maintain or start a healthy diet. Maintaining independence can take many forms as well. It can involve driving, helping with finances, for example, and also letting others in can help to alleviate some of the anxiety and frustration by simply talking with others. And while you may be knee deep in the reality of your situation, sometimes it can be helpful. As you let others in, they ask questions about your diagnosis. This can sometimes help reframe the reality of what's going on. Also, as you share your diagnosis, you may choose to share your goals. This might include spending more time with family, building your legacy, or pursuing a hobby. Once you allow a loved one to learn of your goals, they can be instrumental in helping you to achieve those goals. And remember, with pulmonary fibrosis, goals are so very important, as is maintaining flexibility with goal attainment. I remember when my father-in-law was really ill with his lung disease, and he would become extremely frustrated that he couldn't do some of the things that he loved. And that really made him quite sad and depressed. One thing in particular was golf. This man loved golf more than most things in life. Being from Ireland, he played most days of his whole life, and it broke his heart to not be able to play 18 holes. He had shared that playing golf was an important goal of his. So once he shared this, we were able to help him reframe this goal, which eventually turned into playing part of a par 3 and not doing a lot of walking, driving the cart right up onto the green and putting. And so it was important that he shared his goal with us. And in doing so, we were able to help him achieve a reframed goal. Other benefits of sharing your diagnosis with others is advocacy. Your loved one can help come up with some questions for the care team, and they can also remind you of questions during a clinic visit, as these visits are sometimes derailed by test results that you may have received. Or these visits may be driven by the agenda of the healthcare provider, which I hope isn't the case. They can also share their strength with you. You may be having a difficult day. You might need some assistance or maybe just a hug. Also, family and friends can share their strength and concern with one another. By telling friends and family, they are no longer in a vacuum and can share with each other their concerns and strengths. Everyone's going to go through this journey differently and feel certain ways at different times. And it could be your pillar of strength might need their own pillar some days, and they might find that with each other. And also, by letting others in, your burden might be eased some. Other benefits to letting others in are empowerment. You can actually empower caregivers by allowing them to help you. They really and truly want to know the best way that they can help. And by letting others in, you don't have to put on a happy face all the time. They know what's going on with you, and you can have bad days. You don't need to be all sunshiny all the time. So as you prepare for the talk, it might be helpful to make a list of close friends or family or anyone else that might be a part of a positive support system. Being straightforward about your fears and anxieties is essential to getting the support that you need. You might list coworkers, church members, This list is really inclusive of whomever you choose to tell. And remember, friends that you see or socialize with less often might be told by a family member. Sometimes it's helpful to designate a person to give the information to others. And you might not want to share everything your doctor's told you. In that case, it might be helpful to prepare an answer like, I'm not ready to talk about that right now, or I'd rather not say. You also want to think about how you want to share the information. Are you more comfortable doing this in person, over the phone, in a letter, or an email? Then think about what you want to share. An outline might be very helpful as you anticipate some of the questions and what you want people to know. This may include things like, what is pulmonary fibrosis? How is it treated? And more importantly, how can they help you? It's also important that you assess your readiness to share your diagnosis with others. If you're not comfortable discussing your diagnosis with friends or family, you may choose to start with a support group or a mental health counselor. In the setting of a support group, you will meet others traveling a similar path and gain some information, maybe even some strength and empowerment from the setting. Alternately, you may consider talking with a mental health counselor. Seeking this type of help can help you not only process what's going on, but also help you sort out the best way to share your diagnosis with others. And be ready for the issue of emotions in this setting. Not only do you have to deal with new emotions that you're feeling, but you also have to cope with the reaction of the person you're telling. This can result in some added stress. So prepare for this and have the talk when you are ready to do so. When you're having the talk with friends and family, you may want to discuss potential triggers to avoid. Trigger points can be different from each person. They may involve your prognosis, that may involve religion, it may involve unhelpful advice. You may want to establish a ready response when you need to cut someone off or redirect the conversation. You may say something like, sometimes I get tired of talking about pulmonary fibrosis. Can we talk about something else? You may be inclined to redirect someone if you hear some unhelpful comments, such as, I'm sure you'll be fine. How long do you have? Don't worry. Or my favorite, I know just how you feel. You may also ask how they are doing. This gives them permission to discuss their feelings as well. And while this is an important part of having the talk, it can take a good bit of emotional energy. So again, prepare yourself for it. And don't ignore your need to talk with someone. Recall some of the barriers we talked about previously. Don't let an inclination to protect someone keep you from opening up. Remember, in most cases, they want to help. And by letting them know what will be most helpful for you, everyone has different needs and your needs may change over time. Having a discussion about your diagnosis isn't a static situation. Things change. And try to hold space for one another. You might ask yourself, what in the world does this mean? Well, holding space can be very, very impactful. It simply means letting a person be fully in their emotion without trying to fix it for them or making them feel better. You just let that person express themselves without fear of judgment and without having to worry about how they're going to be coming across. It's almost like creating a protective bubble around the person for their thoughts and feelings they're having in the moment. You can be present for this experience in each other's life journey by simply holding space. After you have the talk with others, what do you need to do? Well, check in with each other, see how things are going. You can continue to hold space for each other as the need arises. And while your diagnosis may seem to permeate every aspect of your life at times, it's important that you talk about other topics unrelated to pulmonary fibrosis, such as interests and hobbies. Sometimes you just need to take a break from talking about the disease. So in summary, I want you to think about some of the barriers to discussing your diagnosis with friends and family and how you might address them. Importantly, recognize the benefits of having the talk with those closest to you. and prepare for the talk. Be ready. Remember, there is no right way to talk about your pulmonary fibrosis with friends and family. The most important thing is that you share your diagnosis in a way that feels right to you, to those you feel need to know. You are not alone. Invite others on this journey because they want to help. And with that, I'm glad to take any questions.
Welcome, Heather and Lanier, to our live Q&A session. I wanted to thank you both for your wonderful, informative presentations. I always leave the summit with new and more information on how to help patients, and sometimes even a different perspective on things. So thank you both for providing me with that on these very important topics. Now let's get started on our Q&A part, because we've had a lot of good questions come in. The first question is there any source of innovation for broader tubing, since the narrowness of the existing ones, called the high flow, still self-regulate to a flow less than the concentrators would otherwise provide when hooked together for those on more than one concentrator?
Well, thank you for that question. I know that's a difficult one for sure. We have a lot of patients that are having to use higher flow and on two different concentrators, so it's difficult. I would say just make sure that you have the proper tubing. Talk to your respiratory therapist to make sure that you have the one that is proper for that particular flow. And I would also check with your DME provider to see what they have available. I know that some patients have come to our respiratory therapists when they're here in the clinic and just say, you know, is this the right one, or is something better that I can use? And they can often help out with that. And then I know that there's, you know, some manufacturers are working towards new technology to help out with that. So I'm hoping that we'll have even better things in the near future.
Great. The second question, my pulmonologist thinks palliative care is too soon for me, and I know it is not. I'm struggling with daily living, with being on oxygen all the time. What can I do when my doctor is not on board?
That's a great question, and that's a really good concern that I'm sure a lot of other people share. I would tell you, well, first I would ask, have you had, you know, a discussion with your physician about what their reservations might be? Maybe they don't understand the nature of palliative care, and they're maybe confusing it with hospice. I will tell you that you could ask them again, saying, I would very much like a referral to palliative care. If they're not willing to do that, there's a resource at your disposal. If you have access to a computer, you can go online to the Center to Advance Palliative Care website, and it's a wonderful repository of information. And it's also going to list some centers that provide palliative care, and you might be able to reach out on your own to one of those centers, or at least find one close, see if they have a recommendation for you. Okay, so there are some resources out there, but I might circle back one more time with your pulmonologist and let them know that it's very meaningful for you to do this to help with your symptom management. And if they're not willing to help out, explore your resources and maybe seek one out on your own through that website, which was the Center to Advance Palliative Care. That's one of many, but it's a good one.
And maybe kind of a follow-up to that question. At what point is palliative care recommended?
I think really, if there is a diagnosis, it's a serious diagnosis, it can be anytime. It can be early in the disease, if the patient's ready for that, if you're ready for that, you know, just seeing what aspects they can help you with. It also can be late in the disease as well. It can still be helpful at either point. A lot of patients I have seen have wanted it a little bit later once they have kind of got a grasp of everything and see what's going on. They don't want it till later, but we do recommend earlier because we do feel that that is helpful earlier on in the disease.
The next question is, are palliative care and hospice given at the same time?
That's a great question. And I think a lot of providers have that same question as well. As we heard from Heather, palliative care and hospice are two different services that offer similar services, whereas palliative care is indicated at any time during the disease trajectory, and hospice is indicated towards the end. So if you were on hospice, you don't need to be on palliative care at that point. So you would be on one service or the other, okay? So they're going to offer similar care with the differences that Heather spoke about previously in her talk. But I've not known any patients to be on both services simultaneously.
These are great questions. The next one, can a person be involved with palliative care and enroll into a clinical trial or be on the transplant list?
At our center, I think I have seen that happen. I think it also depends on which particular clinical trial. Some of them have different rules and things that they do, but I have seen patients, in palliative care and on clinical trials as well. But it depends on the trial. And then the same for the transplant. It would depend on the center and whatever that they have as far as their particular rules and regulations. Do you have anything to follow up with that?
I'd say, at our center, my experience has been that patients have been on palliative care and simultaneously listed for transplant. Sometimes when a patient becomes much too sick to receive a lung transplant, then they'll transition to hospice. But palliative care and transplant at our transplant center is acceptable. But again, it's a center by center decision.
The next question. I've heard that choosing hospice means choosing comfort measures in place of curative measures. You are saying that palliative care does not make the distinction? I realize you said this more than once and in more than one way, but I want to be as clear as possible.
Yeah, just to follow up with that, I think I did say that several times in my slideshow, and I just wanted to explain a little bit further. Yeah, hospice really is taking over the care. There's not usually too many curative measures going on at that point. And it's usually at the end of life when there's around 6 months to live. Approximately, doesn't have to be exact. And it can be renewed as well. But generally speaking, we're not seeking curative measures at that time. Were you going to say something, Lawyer?
I was just going to add on that symptom management for both hospice and palliative care occurs throughout each service, but the curative therapy is what hospice does not seek.
Thank you.
So to kind of follow up on that question, if a patient does then transition to hospice, does that mean that they're not allowed to go see their specialists anymore, or do they have to stop, let's say, their antifibrotics or something like that?
That's a very good question. At our center, when a patient is under the care of hospice, they are generally the team that is taking care of the patient 100%. And so once a patient transitions to hospice with our center, we're still available for a phone call, but at that point, it's usually quite difficult to get into clinic, and we're allowed, the hospice team is now taking care of the patient. And so oftentimes when they're on hospice, curative therapies are not what we're seeking because there's not a cure at that point. And so oftentimes those curative therapies, which many of the therapies for pulmonary fibrosis aren't curative, but those will often stop with hospice. However, the symptomatic therapies for shortness of breath, cough, pain, those continue wholeheartedly.
Yes, I would say that has been my experience exactly.
How about the cost difference for hospice versus palliative care? Is there one?
I think that's going to be, well, let me tell you this, both are covered under most insurances. the degree to which is probably going to be dependent on your policy. And so that's something that I would have investigated. But both hospice and palliative care are covered services for the most part. The exact cost, I don't know what it's going to be for each person.
And there was a kind of a follow-up question about explaining Medicare and secondary insurance coverage of hospice, if any.
I think Medicare would cover a portion, and then if someone has secondary insurance, that would, follow up with that with maybe some more coverage. If we have a social worker that we work with on our team, actually, that does help out with some of those questions. I often go to her to ask those things, but generally speaking, you could check with a social worker if you have one that works with your team. I think that would be helpful as well.
The next question, and this is to both of you. Have you experienced a family member that you were directly involved with hospice or palliative care?
Our own family member?
That's what I believe, kind of more of a personal level,
Sure.
Having done that, gone through it.
I'm glad to share. I'll make it short. My mother-in-law, who had Alzheimer's for years, suddenly developed lymphoma in her brain. And so we decided that she should live with us and have hospice. And so my personal experience with hospice was this year from February to March of this year. And personally speaking, the hospice experience was fantastic. It allowed us to have nurses in the house, caring nurses in the house, a care team that was absolutely amazing, nursing assistants and nurses. And in our situation, I think that hospice was probably the most important aspect in making sure my mother-in-law was as comfortable as she could possibly be. And that is one piece of her journey that brings a smile to my face to this day, because I don't think she wanted for anything or hurt during that process. And I don't know that that would have been possible to that degree without hospice. So my personal recommendation is that if hospice is indicated, please take advantage of that service, because it's wonderful.
Thanks for sharing that. I know that's something very recent, so very fresh in your mind. I haven't had a family member, an immediate family member with hospice and palliative. But so many patients, and some of them are almost like family, but in some ways. I've had recently, though, a friend who had went through hospice, had a diagnosis, incurable cancer, lung cancer. So that particular friend took on hospice right away when they found out that the treatment options were really not there at that time. So actually she was able to still go to lunch with friends and, get around the town and things like that. Certainly the hospice people were checking on her all the time, but she was really able to live her last several months as she would, close to her family and close to her friends. So that was really nice to see.
And I'm going to add one more thing in terms of family members. Of course, I just shared about my mother-in-law, but an additional aspect to hospice that I've read about but didn't experience until now is that they're there not just for the patient, but for the family members as well. And so while my mother-in-law is their primary concern, they would have conference and talks with us separately for those in the family that needed some of their services as well in terms of counseling that was offered. And even afterwards, the hospice team still would reach out to the family members.
Those are hard things to talk about, but important and great information. Very, very good information. The next question is, how do you know when you are ready to have the talk with your caregiver or family? So from a patient trying to talk, I think this goes along with Lanier's talk.
This sounds so simple, but it's so true. I think the moment you're ready to have the talk is when you feel like you're ready to share that information with someone. Just how do you know when you're ready? When you feel like it's time, when you feel like it's time to invite that extra layer of support from family members, when you feel like you're ready to have that discussion. There's not a green light that's timing for everyone, but when it feels right to you, I'd say go on and have the discussion. And if your audience, your family member, your friend isn't ready to have the discussion, maybe give them a little bit of time. But if you think it's time, you should have it.
The next question is, how do you react when people tell you they hope you get better? And what do you do when a family is in denial over the disease that you're dealing with?
Wow, that's a really good question. One I haven't thought about much, but it's an excellent question. I honestly think that if someone, just like a friend or like casual acquaintance, were to be, how are you doing? I would be honest. I wouldn't, go into a ton of details if you don't feel comfortable, but I would just say, you know what? Thank you for asking, but I'm not doing that well because I have a new diagnosis and this is what it is, but we're working through it and I'm following with, these certain providers and these centers that are trying to help me. If it's a family member, I would probably, go into more detail about what the diagnosis is, even if you're don't even know how to come to grips with it yet yourself. I think it would be good just to express it, to say like, you know what, it's a diagnosis and I'm scared. And I think it's okay to say that.
Absolutely. It's whatever you're comfortable saying to whatever the audience is. And remember, it's perfectly acceptable to pivot. So if you didn't want to talk about getting better or, people say some things that are just kind of crazy, you just pivot the conversation and you can say, yeah, sometimes I just don't want to talk about it. Can we move on to something else? It's okay to pivot away and not entertain the question directly if it's not a good time for you. But if you're comfortable doing so, go for it. And if you're not, pivot. Today's a tough day. Can we talk about something else? You don't have to answer if you don't want to.
That's great advice. I think our last question here that has come through is, should palliative care be recommended for every PF patient?
Okay, that's an excellent question. I think if a patient comes to us, to our team, and have a diagnosis of IPF, and with what we see on imaging, on like breathing tests, on different things, looks serious, I think fairly early on we would recommend palliative care, especially if there aren't a lot of other options. I think I would bring it up, at least so you know about it, at least so the patient knows about it and is aware it's available. I think it's a lot to handle getting that diagnosis right away. So it could be second, third visit that's brought up. But I think it completely depends on the situation of what kind of pulmonary fibrosis that particular patient has, how that patient is doing, what the prognosis is. I think it really depends, but I know it's very important.
I think it should always be a consideration, even if the timing's not right now. But putting it into clinical perspective, definitely.
Great. Thank you both so much for being here, and thank you so much for your presentations and answering all these questions. And to the audience, thank you all for your time and attention and all these wonderful questions. Thank you again, and have a good rest of your evening.